Hi everyone, my name's Ketang and I'm one of the doctors in South Yorkshire in the UK. Thanks for joining us on a Saturday morning. I'm hoping we'll have seen some of you before, but if not, then welcome to the next webinar in my Obliques Radiology series. So over November, December and January, we'll aim to cover all the imaging modalities that doctors and healthcare professionals tend to come across in the hospital. So last week, Dr. Hughes took us through abdominal and pelvic x-rays. So today we'll be starting the MSK section of the series. So Dr. Henry de Boer will take us through a structured approach to hand and wrist plane films, which are some of the films that junior doctors typically find more difficult to interpret, and that's also me included. So he'll go over how to cover a logical approach to interpreting both of these plane films and discuss some of the cases with us. So we'll just crack on with it. So Henry, I will hand over to you if that's okay.
Yeah, thank you, Kev, for that introduction. So I'm hoping that you can all hear me and see my presentation. If you can't, then please put in the chat. But otherwise, we'll make a start. So yeah, my name is Henry de Boer. I'm one of the ST3, so third year registrars in Sheffield from the UK. So I'm going to talk to you about radiographs in hand and wrist trauma. So we're going to quickly go over some of the bony anatomy of the hand and the wrist. Which is something I think getting the terminology correct can be quite tricky, and there's a lot of bones, carpal bones particularly confusing, so we'll go over that. Quickly look at sort of normal alignment and how to look at a hand and a wrist radiograph in a trauma patient, and then we're going to try and spend at least sort of 40 minutes of the talk going through some cases. So I'll be showing the cases, giving you 30 seconds to a minute to have a look, and then we'll go through the answers together. So this is a normal hand radiograph, and what I'm going to do is show you some circles, and I'm going to give you a couple of minutes just to have a look through, and for each circle try and name either the joint or the bone, and ideally the specific bit of the bone which has been circled. So have a look through those, see if you can work out the answers, and then we'll run through them in a minute to 2 minutes. Perhaps if you comment in the chat ready when you think you've had a chance to look through them all, that would be useful. Okay, it's starting to get some people that are ready, so give you another 30 seconds and then we'll run through them. Okay, so let's start going through the answers. So when I look at a hand and a wrist radiograph, I like to start proximally and work my way distally. So from proximal, so we've got the radius. On the radius, there's the radial styloid process. This joint here between the ulna and the distal radius, so distal radius, distal ulna, is the distal radio-ulnar joint. There is a joint more proximally towards the elbow, which is the proximal joint. Got the ulnar styloid process, which is this sort of tip to the end of the ulna. And then in this space here, we've got something that's called the triangular fibrocartilage, which isn't something you'll normally see on a trauma film as particularly an important finding. But if we're talking about arthritis, this is important because it can calcify. Then we've got the carpal bones, which we'll cover on the next slide. So we'll move on from those for now. And then we've got the metacarpals. So one for thumb metacarpal, index finger, middle finger, ring finger, and little finger. And when we're talking about the hand and the wrist and anatomy, it's really important that we don't use the terms first metacarpal or first finger, because that can be a bit confusing. Some people will go, well, is the thumb the first finger or is the index finger the first finger? So I would always advocate using thumb, index, middle, ring, and little finger when talking and describing hand and wrist radiographs. And the metacarpals have a base, a shaft, a head, and then the junction between the head and the shaft is the neck. So this would be the base of the right ring finger metacarpal. This would be the neck of the right little finger metacarpal, and this would be the head of the right ring finger metacarpal. The joint between the metacarpal and the proximal phalanx. So the fingers, there are 3 phalanges, so proximal, middle, and distal phalanx, and this is the metacarpal phalangeal joint, or MCP joint. So the answer to this one would be right middle finger MCP joint, or metacarpophalangeal joint. So this is then the proximal phalanx, and this is the shaft of the right ring finger proximal phalanx. And then describing the joints, so there's a proximal interphalangeal joint, so the first joint between the 2 phalanges, and a distal interphalangeal joint. So the answer here, I think we've done that one, yeah, right ring finger proximal interphalangeal joint. This would be the right middle finger shaft of the middle phalanx, right middle finger distal interphalangeal joint, and then this is the distal phalanx of the right index finger, but specifically the very end we call the tuft. So that's the tuft of the right index finger distal phalanx. In the thumb, you'll see there's only 2 phalanges, so a proximal and a distal phalanx. There isn't a middle phalanx like there is in the fingers, so we refer to this as the thumb interphalangeal joint. This little fleck of bone here is a sesamoid bone. So this bit of bone is actually within a tendon, and that's what makes it a sesamoid. So the bone itself is within the tendon, and that's not to be confused for a fracture. Okay, so then we've got the answers coming up, which we've talked through. So the carpal bones. So I think this is where people can get very confused. It can be difficult to know which carpal bones we're looking at, and I think it can be quite intimidating to start with. So we're going to just run through which each bone's called, how I like to think about them to try and remember them, and there's a mnemonic at the end as well to try and help you. So this is the thumb, so this is the base of the thumb here, and this is the index finger to try and orientate ourselves. We can see the radius and the ulna with the ulnar styloid process here. So this is the scaphoid, and in the carpal bones we've got the first carpal row, which we call the proximal carpal row, and the distal carpal row. So they come in 2 lines, with this being the radiocarpal joint, this being the intercarpal joint, and this being the row where we have the carpal metacarpal joints. So we've got the scaphoid, and scapho is Greek for boat shaped, and it is sort of boat shaped. The navicular in the foot is sort of an equivalent bone, so I think navicular is Latin for boat, and it's got that similar sort of semi-crescent type shape. So that's a scaphoid. This is the lunate. And when we look on a lateral radiograph, it looks like sort of a half moon, which is why it's called lunate. It looks like lunar. This is the triquetrum. And then the pisiform is this P-shaped round bone here, which is again a sesamoid bone. So scaphoid, lunate, triquetrum, and pisiform is the first carpal row from the thumb side, so the radial side to the ulnar side. So then going from the radial side to the ulnar side in the distal carpal row, we've got the trapezium, which is under the thumb. So they rhyme, which is how I remember that. So trapezium, under the thumb. The trapezioid sounds like trapezium, so it's next door. So trapezium, trapezioid. Then we've got the capitate, which is the biggest carpal bone. So I remember that capitate sounds like capital city is usually the biggest city. So the capitate, and then the hamate. And the hamate has this hook on it. So the hook of the hamate. So this is the hamate. So run through those again one more time. So we've got scaphoid, lunate, triquetrum, pisiform, trapezium, trapezioid, capitate, and hamate. So there we go. And the mnemonic that I was taught at medical school, and some of you may know, there are other mnemonics available, is some lovers try positions that they can't handle. So looking on the lateral radiograph again, we'll go through where we see the carpal bones, and this can be very confusing, I think, for people that aren't used to looking at hand and wrist radiographs, but it is important because you can see subtle fractures and alignment abnormalities on a lateral radiograph that are really important to pick up. So I'll just go back one. So we've got the radius here, and the classic alignment that people talk about is the lunate, which is this sort of crescenteric half moon shape sitting on top of the radius. And then this is the capitate here, and these should all sit in a dead straight line. So people talk about a teacup with an apple in it, or sort of a saucer, teacup, and apple, and these should all sit in a nice alignment. So there's the lunate, capitate sitting in that, so the apple in the teacup. The scaphoid sits here, sort of looks like a sideways boat. Pisiform sits on the volar aspect, so it's the most forward, most anterior bone, and the triquetral bone is out of the back here. And this is important to remember, because if you see bony fragments in the dorsal aspect of the wrist here, that's often a sign of triquetral fracture. And you won't see it on an AP or frontal radiograph. You'll just see a little bony fragment out the dorsal side of the carpal bones, and that is usually a triquetral fracture. And the back of the dorsal radius here should be really nice and smooth. Any interruption of this line, you've got to be suspicious for a distal radius fracture. And then the trapezoid and trapezium are up here. Not something you will see much pathology on a lateral. And then again, so here is the proximal carpal joint. And when we look at the wrist and the carpal bones, these joint spaces should be uniform, and they should be equal throughout all the joints. So you should see these nice joint spaces being pretty even and uniform the whole way around. And we call this sort of seeing the light, or the light of day sign. So if you can't see the light of day through these bones, you have to think about, is there a dislocation or a fracture? So proximal carpal row, mid-carpal row, and distal carpal joint. And on the lateral, nice straight line, radius with the lunate and the capitate all sitting in alignment. And again, just to remind us. So let's move on to some cases, which you understand is what you all like. So Some of these cases are normal. Most of them, though, are abnormal. So there's pathology and fractures or dislocations to spot on most films. They get progressively harder. I suspect you'll find these quite tricky, and that's intentional, because if I just showed you obvious fractures, anyone can spot those. I think what I'd like to do is try and highlight some of the important fractures or the easily overlooked injuries, so that if you're looking at these films overnight or trying to make a decision, you have seen most of the important pathology and the ones that you can miss. And then if you've seen it before, you'll know what to look for, and hopefully we'll spot it. And if we get to the end, and I've got about 30 cases, so we might not have time to go through them all, but hopefully we should cover all of the injuries that you'll likely ever see. So first case, I'll give you 40 seconds to a minute, something like that. And if you put in the chat box what you think is the correct answer, so either normal or put in the pathology that you can see. And with these radiographs, the key, and what as radiologists we try and do, because certainly where we work in Sheffield, the A&E doctors or the nurse practitioners that work in our minor injuries or fracture clinics are very good at looking at these films, and they don't really miss very many injuries at all. But what we can add is sort of the slightly more descriptive reports. So if you see a fracture, try and describe how it's displaced, how it's angulated, where it extends from and to. Is it intra-articular? So does it involve the articular surface of the bone that you're looking at? And are there any other associated injuries? So I can see, yeah, some few answers coming in. Okay, so let's start going through the answer for this one. So we've got an AP and a lateral of the hand and the wrist. Okay, yeah, nice. So all the answers I can see have been correct so far. So starting proximally working distal. So the way I look at these is, I mean, it sounds quite obvious, but you really have to trace the cortex of every bone to make sure you're not missing any fractures. So as I'm doing that, I'm noticing a regularity here on the radial aspect of the radius and here. So that's very suspicious for a fracture on the AP. And I think there's some slightly jagged, lucent line that crosses the distal radius here. So we'll come back to that when we look at the lateral. Looking at the carpal bones, nice joint spaces. They're all nice and even. I can see space between all the carpal bones, between the carpal bones and the metacarpal bases. And I can't see any cortical steps or breaks or lucent lines to the carpal bones. And likewise for the metacarpals and the base of the proximal phalanges that we're just getting here as well. So on the AP, this distal radius doesn't look right. On the lateral, tracing the bones, and remember what I said about the dorsal aspect, the posterior aspect of the distal radius should be really smooth. And this is not smooth. There's a step and a fragment here, and we can see the fracture line comes across to involve the articular surface. So yeah, there is not smooth fragment here involving the articular surface. So I would call this an intra-articular fracture of the left distal radius, and it's slightly impacted. So the radius is slightly shorter than the ulna here, so slightly impacted, but it's not particularly displaced, and the angulation is actually quite a normal angulation. You should have ever so slightly some volar angulation to your distal radius. So distal radius fracture. next film. So these are two different films, so these are not from the same patient. And the reason I bring this up is because these are both distal radius fractures. So this one has displaced in a volar direction, so towards the palm, and it's angulated in the volar direction. This one has displaced posteriorly and angulated posteriorly. And whilst I don't think this is important to use eponymous names, and I would never use them in my reports, I would always describe the fracture. People like asking, what's the eponymous name of this fracture, which is why I put them in. So when it goes volar, we call it a Smith's fracture, and when it's posterior, we call it a Colles fracture. The Colles fracture is typical of an elderly female patient, and we see the Smith fracture more commonly in younger patients. Why that is, I don't know, but there's a Smith fracture and a Colles fracture. So again, I don't think these are important to remember the names, but people will ask you, well, what's that? So that's why I put them in. So next case. So this is, again, this is just one series of films from the same patient. I'll give you 30 seconds to a minute. Okay, so yeah, answers in the chat when you're ready. I see one answer in so far, so I'll give you another 10 to 20 seconds. Okay, so let's work through these films together again. So we've just got fingers this time. So starting proximally and working distally, tracing the bones. Not much on that little finger. Here is catching my eye, not quite normal, maybe a little bit of a lucent line through the neck here of the metacarpal. But I think you could be forgiven for not spotting that on the AP. That is subtle. So that's the only thing there that's catching my eye, but it's subtle, and I would definitely be wanting another view to have a look at this. So we've got an oblique, and on the oblique you can see much more clearly, step in the cortex, lucent line across. So that's a transverse fracture through the neck of the, don't know what side that is, so I can't say the side, but of the ring finger metacarpal neck. Slightly displaced, but not much. And I can't see any other injury. And we get a lateral film, which helps you work out if it's displaced or angulated to the dorsal or the volar aspect. But actually these metacarpals, when you're looking sort of down the hand, are all nice in line, so it's not particularly angulated. So I think everyone that's put an answer in the chat box was correct. There we see it, and if we zoom in, it's there, but it's subtle. Metacarpal neck fracture of the ring finger. Next case. Yeah, so it's starting to get some correct answers coming through in the chat. So this one is quite straightforward. So again, tracing all the bones on the AP. Looking okay so far. Yeah, and here there is a fracture. You can see the cortex here is irregular, it's broken as a step on both sides with a lucent line running in between. And on the oblique, we can see again, step in the cortex, lucent line, but not particularly displaced. So I would probably describe that as a fracture, transverse, minimally displaced fracture to the base of the little finger, proximal phalanx. Okay, so next case. Sorry, I think I should have said for the last couple of cases, so we're starting as well. Slightly easier cases, but also the ones that are really common. So distal radius fractures, the most common fracture that we see. Fractures of the metacarpal necks, really common, particularly in people that are punching things. And then phalangeal fractures, incredibly common. Okay, yeah, so starting to get some answers coming through. Some people correct, some people slightly less correct. Wait for a couple more answers to come through so we can get a consensus for what we'd call this. And it's really good that I can see you're all trying to put loads of detail into your answer as well, which is good to see. Okay, so let's have a look at this film. It's on the AP, starting proximally, working distally, as usual. So I think on the AP, not a whole lot to see. There's something we've not talked about so far. So after looking at the bones, the joints and the alignment, just have a glance at the soft tissues. Okay, it's easy to forget that you can see soft tissue on a plain film, but have a look. Is there any swelling, any foreign body, anything that can draw your eye towards a particular area of swelling and look for an injury more closely? So nothing on the AP. On the lateral, and having a look. So here, the alignment's not quite normal. This base of the distal phalanx of the thumb should sit nicely on the proximal phalanx, and they're not. So this is dorsally subluxed, and there's a fracture here. So this slight step doesn't look normal, lucent line. So what's happened here is what we'd call an avulsion fracture. So the flexor tendons insert onto the bases of the metacarpal, or the phalanges, sorry, here. So there's one here and one here, so flexor tendon, and that's pulled a bit of bone off the base of the distal phalanx. So another name for this is a volar plate avulsion injury. You might hear that term. So volar plate avulsion injury with dorsal subluxation. And that seems to be the consensus opinion in the chat. So Jeremy's call it a mallet injury. So a mallet injury, I think we'll see one later, but a mallet injury is where you get this sort of flexion deformity, and that would be an extensor side injury. So when you get the volar plate avulsion, you can't flex your thumb, so it'll be stuck in sort of extension. And these can be really subtle, but they're important to spot, because if you don't immobilize patients with this volar plate avulsion injury, you can get sort of fixed extension deformities. So they're important to spot. Yeah, so there it is. Okay, so next case. Okay, so let's look at this film together. So again, as always, I think it's important to have your sort of system of looking at films, proximal to distal. Carpal joint spaces look okay, and then tracing the cortices of the carpal bones, and there's a lucent line through the scaphoid with a step and a break in the cortex. But when you see the abnormality, make sure you look at the rest of the film, because there might be a second abnormality. But there's nothing else that I'm seeing on this AP. So just this scaphoid. Looking on the lateral. And maybe just a lucent line through the scaphoid and the lateral, but I think you'd be really hard pressed to call that a fracture just on the lateral. And the way I would describe this is exactly as Georgia Mansell has said. Absolutely nailed it. So it's a transverse fracture to the waist of the scaphoid. So the scaphoid has a proximal pole, a distal pole, and a waist. And people may ask you questions about avascular necrosis and scaphoid fractures. So the blood supply from the scaphoid comes in at the waist and distally. So it comes from distal / the waist. It's a bit variable, and then moves proximally. And the reason this is important is because if you get a fracture of the waist, you can disrupt the blood vessels that are running this way and get proximal pole avascular necrosis. So if someone asks what's the most common bit of the scaphoid to have avascular necrosis, it's the proximal pole. And the more proximal the fracture, the more likely you are to get avascular necrosis of that proximal fragment. So a fracture here would be really high risk of this small portion proximally not healing. So avascular necrosis or non-union. And if someone asks you, if the request says query scaphoid fracture or pain in the anatomical snuff box, fall onto abstract's hand, but it looks normal, scaphoid fractures can be really tricky to see. So we will ask for a full scaphoid series. So we'll have, as well as AP and lateral, we do sort of what we call a Zitter's view. So we get ulnar deviation, and we do sort of another oblique projection as well. And if they still look normal, we would recommend repeat follow-up x-rays in 10 to 14 days and treat for a fracture in the meantime. There are some centres that, rather than following up with x-ray, they'd go straight to do an MRI scan of the scaphoid, which is really sensitive for scaphoid fractures. But sort of availability and cost of MRI in Sheffield, we follow up and treat if we think there's a scaphoid fracture that we're not seeing. So there it is. Okay, so I will quickly talk through this film as well, because I think there's an obvious lucent line step in the cortex fracture here. But the reason I put this one in, so this would be a left index finger proximal phalanx oblique fracture through the shaft of that proximal phalanx, is because the lateral looks completely normal. There is no abnormality on that lateral view at all, which just shows the importance of obtaining sort of two projections, but making sure you look at all the projections. It's really easy to look at the AP really closely, and then you'll look at the lateral next, but you've already made your mind up that it's normal or abnormal and not fully look at the other view. So always look at two views. There you are, it's invisible on that view. Okay, so next case. Okay, so again, let's have a look through this one together. What we can see are the carpal bones, spaces look normal, tracing the outlines, no fracture, metacarpals, no fracture, phalanges, no fracture, looking at the joint spaces, the alignment, and then having just look at the bony sort of detail, any bone lesions, less common in the fingers and the extremities than perhaps on a pelvis. Bone details look normal, and then soft tissues look normal on the AP, and on the oblique, much the same. So yes, I agree with all of you. This is normal. Well done. Okay, so keep those comments coming in the chat. I can see Same sort of 5 to 10 people commenting each time, but there's 130 in the chat, so it'd be nice to have a few more answers coming through. So let's have a look through this one together. So proximal to distal. No definite fracture on the AP, but we can see that the alignment here is not normal, and that's because they're flexing their finger. And perhaps some soft tissue swelling and some increased density in these soft tissues. So when we have a look on the lateral, again, so there is a step in the cortex, lucent line in keeping with the fracture. On the dorsal aspect of the base of the distal phalanx, soft tissue swelling, and there is sort of a flexion deformity here, because when we take these laterals and the AP, we ask for the finger to be straightened. So if the finger is bent, we have to assume that's because they can't extend it. So I would call this a dorsal avulsion fracture at the base of the distal phalanx with a mallet type of deformity. So yes, bony mallet. Well done. I think you're all correct. The answers that I've seen. So next case is similar. So I think we'll just talk through this one again together. So proximal to distal. No fracture, but the alignment here is not normal. This finger is normal, nice straight line, everything aligning normally. But here, there is subluxation towards the ulnar side here, and then coming back the other way. This is all wonky. And the joint space here, see here, we should look straight through the joint space. Be nice, clear, but here, it's just not right. And when you combine that with this subluxation, and then we look on that actually, it confirms those suspicions that there is dorsal subluxation / dislocation at the proximal, or sort of the metacarpo-phalangeal joint. No, sorry, proximal interphalangeal joint, my mistake. Yeah, it's wonky. And that's where it should be normally, and it's dorsally dislocated / subluxed. Question, what is a mallet? So a mallet finger is just describing that, so I don't know if you can see my video, but where you have flexion at the distal phalanx, or to be honest anywhere, but it's a fixed flexion deformity. And a mallet injury can either be a soft tissue, so it's purely a tendinous injury with no fracture, so you might just see a bit of soft tissue swelling, or you can have a bony mallet injury where you have that avulsion fracture. But it's an injury to the dorsal side where your flexor tendon has been disrupted. Oh, so I can see some answers coming through. Give you another 20 seconds to have a look. I can tell they're getting more tricky now because there's fewer answers coming through quite so quickly. Okay, so interestingly, we're having a few different answers this time, which is good. So 3 answers, 3 different answers so far, which is, yeah, good, keep them coming. Be interested if we can get a consensus opinion before I continue. Don't be shy. Yep, keep those answers coming. Doesn't matter if you're wrong. got 3 different answers so far, so only one of them's right. Okay, so our usual pattern, tracing the bones proximal to distal. Okay, so some concern for capitate fracture and little finger fractures. So I don't think there's a fracture. I think these cortices are all intact. Maybe it was this that someone was looking at. Now, this is just very smooth. There's no break in the cortex. I think this is what we call like a nutrient vessel. I don't think that's a fracture, but I think for spotting it, well done. I think if you're concerned and you're not sure, treating it as a fracture, bringing them back for follow-up is not a bad plan. Looking at the alignment, the carpal rows look okay, but then when we trace the lines and the space, this space here between the scaphoid and the lunate is wide. They should be symmetrical, so all the spaces should be the same size. This is wide, and as yeah, Georgia Mansell, you're right. This is the Terry Thomas sign. If you don't know who Terry Thomas is, just Google a picture of him. He was famous for having a gap between his 2 front teeth, and this supposedly looks like that gap between the 2 front teeth. So this is the only injury, and this is an important sign to pick up, because what's happened here is there is a ligament that runs between the scaphoid and the lunate called the Scapholunate ligament, and you can have an injury or a complete transection of this ligament. And if that happens, the scaphoid and the lunate start to drift apart from each other. They start to get wider and wider, and if this isn't treated, then it can lead to really bad deformity of the wrist. So this keeps getting wider, and the capitate will migrate through this gap eventually and start to articulate here, and they just end up in a whole world of problems. So yes, this is a scapholunate injury or scapholunate dissociation. So there's that gap that's wide, but there is no fracture, but there is a scapholunate ligament disruption. Next case. So I can see we've got 10 minutes left. So try and pick up the pace slightly just so we can get through as many cases as possible. Because I think the more that we can see, I think the more useful this will be. Yeah, please keep those answers coming. So let's have a look through together. Tracing the cortices. So if something here is not right, bit of deformity, but there's no step in the cortex and there's not really a lucent lie. The alignment otherwise looks fine, joints look okay, soft tissues look okay. So we look on the lateral. And again, we see this deformity, but no acute fracture. So what this is normal, but there's an old fracture here. So it's a previous boxer's injury. So yeah, so someone's said boxer's fracture, bony growth, normal. So yeah, I don't know if you call it normal. Is it normal? That's a bit of a debate, but there's no acute injury. There's an old fracture here. And this is what healed fractures look like. And because this is such a common injury, you'll see old fractures of these metacarpals all the time. Usually people that get into fights because they're punching things all the time. Okay, so have a look at this one. Okay, yeah, so Kev said don't worry about time limits. So yeah, I'm happy to run over and go through all the cases. So if anyone wants to carry on, just continue on the call. We'll go through all the cases, don't worry. Okay, so Mustafa, I've seen your question. We'll go back once we've done this one. There was no bony growth on the previous. It was an old fracture. The answer was old fracture, no acute injury. There wasn't a bone lesion. I hope that answers your question. If not, let me know. I can show you again. Okay, so let's go through this one again. Again, it's starting to get a bit more tricky. So the AP, tracing all these bones, each finger. So there's a fragment here. There's a fragment here. And the alignment between the base of the little finger metacarpal and the hamate just don't look right. There should be this nice uniform joint space, but it's not. It's overlapping here. So this doesn't look right, and there's some fracture fragments. Exactly where they've come from, perhaps difficult to say. Is the cortex here abnormal? I think it probably is. And then the lateral. Looking for fractures, it's difficult with all this overlying bone. But the reason that we're getting this lateral film is because it doesn't look right here, and we want to know is there dislocation. And you can see that this little finger metacarpal is dislocated dorsally. And I think it's interesting anyway that it's such an obvious dislocation. It's so far out of joint here, but it's relatively subtle on the AP. And that sort of goes to show how important this light of day sign is, or looking for this overlap. And if you spot it and you've only done APs and obliques, which are quite common, and you're not happy, get a lateral film. There might be a massive dislocation that you're missing. You'd hope that clinically this would be quite evident. But if you see the radiographs, don't be afraid to ask for a lateral view as well. So here it is, fragment fracture here. And this doesn't look right. And as we said, the alignment of the capitate and the hamate doesn't look normal. And these metacarpals should all be in alignment. So this is a fracture dislocation. So it's a fracture of the ring finger metacarpal base, the dislocation of the little finger. So I hope you can all see that slightly complex injury. But by spotting these fracture fragments and the not quite alignment here, we basically got the answer, and the lateral then just confirms that. Okay, so starting to get a few answers. Yeah, people saying normal. Yes. Question, is the transparency normal? So the alignment, both views, is normal. There's no fracture. There's no soft tissue swelling. So this is normal. The bone density, is it the bone density that you mean? I'll assume so. Yeah, I think they look okay. Yeah, normal. And luckily, I agree with myself. Okay, so next case. Okay, so before I go through the answer for this one, so it is 12 o'clock now, so if anyone has to leave us, thank you for joining. But I will continue until we get to the end. We've got a lot more cases left. Okay, so let's have a look through this one together. Tracing the cortices. Okay, so no fracture that I can see. Alignment. This first sort of row looks okay here, but then as we trace this middle carpal row, it's lumpy bumpy, it's all overlapping. So if you think of the previous ones we've seen, this is not normal. We should have this nice uniform line like we do here across the mid-carpal row, and it's not. It's all over the place, really. But I can't see a fracture. And these carpal bones, the shape of them also isn't right at all on the AP. And the lateral shows us why it all looks so funny. So if you remember, we should have the saucer with the apple, but the saucer with the cup, and then the capitate, which people talk about the apple, is dorsal to that. They're not sitting in a nice straight line. We'd want this sitting here. So there's this carpal dislocation, and there's different classifications. There's lots of complicated terminology we can use, but probably the most simple ones, or the important thing I think to learn, is whether it's a perilunate or a lunate dislocation. And the way I think about this is a lunate dislocation is when the lunate is in the wrong place. But the lunate here is normally sited on the distal radius. It's the capitate and the distal carpal row that's dislocated. So this is a perilunate dislocation. So that's again showing us those carpal lines are not normal. The lunate and then the capitate dorsal to that. So yes, perilunate dislocation. So next case. And I've just realised, I don't know if you all know, but when we're describing angulation or displacement, we talk about where the distal bit has gone relative to the proximal bit. So if we get some examples, I'll talk that through, but you have been describing them correctly in the answers that I've seen. Okay, so yeah, let's have some more answers, please. Anyone else for an answer? Got 2 so far. Okay, so your question about the previous film was the gap between the ulnar and the carpal bones normal. I'm just going to quickly flash back. Yes, this is normal-ish, because we've got this triangular fibrocartilage that sits in this triangular shaped gap here. But this contour isn't normal. But this specific gap, yes, that probably is normal. Okay, so the answer to this film. So I think this is tricky. I think that's reflected in the comments and the lack of answers. So we do have some vascular calcification. So that is the radial artery, which is calcified. Tracing the bones. So this is catching my eye. I actually can't remember the answer, so we're looking at this fresh together. But this doesn't look normal. I think there's a step there. But the joint spaces themselves otherwise look okay. And the rest of the bones look okay. On the lateral, alignment looks okay. Obviously we thought the scaphoid looked not right, so paying close attention to the scaphoid. I can't really see anything on the lateral, so I would want a scaphoid series on this one, particularly if the history was scaphoid tenderness. But I've called it normal before. So that goes to show that these can be really tricky. And if there was a history of scaphoid pain, then we would definitely be treating them as a scaphoid fracture, doing a scaphoid series and bringing them back for a follow-up film. But no definite injury on that one. Cause of the calcification. So the calcification it's never normal, but you can debate what's normal for age. Most people in their 80s and 90s are going to have some vascular calcification, but the more you've got, could be due to renal failure, could be hypertension, hyperlipidemia. Yeah, all the normal causes of atherosclerosis and arterial disease. If they were 90, you'd probably ignore it. But if this patient wasn't known to have any history of any medical conditions and they were in their 40s or 50s, I would probably comment on it as an incidental finding, because that's quite a lot of calcification, and it could be the first sort of sign that maybe they are at high risk of cardiovascular disease. Okay, so the next case. Okay, yeah, Anna, well done. I'm glad you spotted the soft tissue swelling. But do you think there's a fracture or not? Yeah, so looking through this one together, the bone cortices, the alignment looks normal. Yeah, no fracture, but there is soft tissue swelling here. And you can appreciate the slight soft tissue swelling as well on the AP, but on the lateral, yeah, volar soft tissue swelling, no fracture. This could be due to multiple reasons. Without history, it'd be difficult to say. It could be that there's a tendinous injury. It could be that this is an abscess, infection, lots of things, but the soft tissue swelling, don't forget, look at the soft tissues. Next case. Yeah, the cortical thickness was average, I think, in the previous film, Grace. Yeah, for all of these films, I've tried to, so they're almost all films that I've reported in the last couple of months in Sheffield, but I've tried to pick ones that are otherwise normal apart from the injuries. So avoiding ones without much degenerative change, because I think that can be, whilst probably reflective of the real world, it's more difficult to learn when there's super added degenerative change. I wanted to focus on the fractures and the alignment. So the bone density is probably normal because they're mostly young patients. Okay, so yeah, people are spotting fractures at the base of the thumb. So here is the bone fragment separated from the base of the thumb metacarpal. And this oblique, I think, even more nicely shows that fracture fragment. And it's intra-articular. You can see the step here. So there it is. So intra-articular fracture, base of the thumb metacarpal. And Jeremy, you are exactly right. This is, the eponymous name is a Bennett's fracture. But as I said, with the Collies and the Smith's fracture, I think remembering the names shouldn't be important because it doesn't actually affect management. What affects management is describing the fracture. And these base of thumb fractures are important to know about clinically, and I don't think it necessarily affects how you'd manage them immediately in the A&E department or as a radiologist, but these often require surgical management because they're unstable fractures. And the reason for that is the thumb will get pulled sort of and abducted due to the abductor tendons, because the adductor tendons insert onto this fracture fragment here. So what you have in effect is the thumb having that lateral pull, but no medial pull, so it will subluck. So this is an unstable injury. but it is called a Bennett fracture. And just for interest's sake, if this is comminuted, we'd call it a Rolando fracture. So it's the same base of thumb intra-articular, but it's comminuted, that would be a Rolando fracture. Okay, so next film. Oh, I'm sorry, I've just seen a comment. Old intra-articular fracture of distal phalanx of thumb. I mean, there could be, but if there is, I can't necessarily see it. Perhaps something here, but I think it's probably normal. Maybe they've had an old injury that's healed completely, almost completely normally, but yeah, I'd ignore that. If you think that's an old fracture, I think it's normal. How are we doing for cases? Okay, about 10 left. Okay, so looking at this film, these carpal bones on the AP are not at all normal. This is all over the place, this row, and this middle row, I don't even know where that's gone. The lunate here is a very funny shape, so it's pie-shaped. And once again, I don't think it's necessarily important, but this pie sign is what it's called, is indicative of a lunate fracture. But I think in the real world and outside of radiology exams where they might describe this, you'd see that this is not normal, and you do a lateral, and there you very clearly see the saucer of the radius and the cup is pointing the wrong direction. So this is a lunate dislocation. So if we compare it to the previous, the capitate is sort of in the right place, but it's the lunate now that's dislocated. So that's a lunate dislocation. And I don't think it was spotted by anyone in the chat, but bonus marks if you spot this scaphoid fracture. And the lunate dislocations are associated with scaphoid fractures. The reason for that is because to dislocate your lunate, you have to disrupt the scapholunate ligament, which often results in a scaphoid fracture to cause that disruption. So there it is, that lucent line. Okay, so that's showing these carpal bones are just completely not normal. Particular injury mechanism. So they are usually still falls onto outstretched hands. Yeah, there's not a particularly classic mechanism, but fall onto outstretched hand, I would say, from what I've seen, is the most common. They're not particularly associated with massively high impact traumas. It is usually simple falls. And there's that lunate. Well, I didn't highlight, but yeah, there is a scaphoid fracture there. Just not highlighted it on the answers. And the perilunate dislocation that we saw previously is associated with triquetral fractures, if anyone ever asked you. Right, so next case. It was perilunate dislocation was associated with triquetral fractures. whereas lunate fractures, no, sorry, lunate dislocation is associated with scaphoid fracture. Is there a reason for the association? So yeah, what I was saying was that in order for your lunate to dislocate, you have to injure the scapholunate ligament. So the lunate and the scaphoid are usually held together by a ligament. And if you disrupt that ligament, you can then dislocate your lunate. So because it attaches at both ends, you can often have a scaphoid fracture, which can be the mechanism for the disruption of the ligament to cause the dislocation of the lunate. I hope that makes sense. I would say it's probably more advanced and more anatomy than you would probably ever need to know reporting these films, unless you were either doing a radiologist or doing a hand surgery orthopedic job. Otherwise, spotting the findings is more than adequate. Okay, so waiting for a few answers. I'm going to take the slow answers to be that this is potentially slightly more tricky. Yes, there probably is some osteoarthritis, mild osteoarthritis of the distal and proximal interphalangeal joints, but that's, you could ignore that. Okay, so let's go through the answers. So, tracing the bony cortices. So how do I spot osteoarthritis? So I mean, this is really mild, and I probably, maybe this joint is the one that's most catching my eye. But the way we look for osteoarthritis is narrowing of the joint space and osteophyte formation. And you also see the other hallmarks would be osteosclerosis and subchondral cyst formation. So this is just a little bit narrow, but it's really not severe at all. So I would say let's not focus on the osteoarthritis. So the steps here and lines across these middle and ring finger metacarpals. But these look old. They look like healed old fractures. But what catches my eye is on this sort of oblique view, the metacarpal alignment is not right. These are all bunched up, and then there's a big gap, and then there's this index finger. And if we look at the gaps between the metacarpals, although it's not a dedicated wrist film, space here between carpal and metacarpal joint, space here, but this base of the index finger, there is no space and it's overlapping the carpal bones here. So that's not normal. So I am confident that there's going to be a dislocation here. So yes, there's a gap. And that's, again, showing that overlap there. So that's a dislocated index MCP joint. And if you think that's subtle, which if you're used to looking at wrist films, you should be looking at that joint space and spotting that. But that goes to show the value of a lateral, because that would be very obvious on a lateral. So next case. Yeah, red dot. So in most centres, and particularly in Sheffield, when the radiographers take the films, if they think there's a acute abnormality, they'll put this red dot on the film. Some of them have actually a red circle that appears. Yeah, they'll write red dot if they think they can see a fracture. And now, the radiographers are usually quite good. So if they say red dot and overnight you're looking at the film and you can't see a fracture, if you're very confident, then you can disagree. But I would say, particularly if you're quite junior and you're not sure, but it's been red dotted, but you don't see the injury, go and ask the radiographer what they'd seen, because they take lots of these films and they get quite used to spotting abnormalities. Okay, so the answer for this film, yes, I would describe this as a fracture here, otherwise normal alignment, minimally displaced. So I'd say minimally displaced, comminuted, right index finger distal phalanx fracture. And the reason it's comminuted, which means broken into multiple parts, is because we can see there's at least sort of 3 fracture lines. So it's fragmented or comminuted. Oh, and it's through the tuft of the index finger distal phalanx. Okay. Okay, so I'll run through this one because I have a sneaking suspicion this is the same film that we saw one before last, because we can see base of the index finger not in normal alignment here, and there are also old fractures here and here. So I think that's not a coincidence. I think that's the same film. Yeah, I'm not sure why that's come up twice. Apologies. And yeah, it is. Yeah, index finger. Try not to use second CMC. It can just lead to confusion. I would strongly advocate thumb, index, middle ring, and little fingers. In the toes, it's okay to use numbers, I think, but in the hands, use the name. And yeah, old fractures. And this is just a close-up to really demonstrate and hammer that home. So this is the same film again, and then they've had it reduced. So it's been manipulated, and now we can see that joint space has returned, and there's no longer overlap of the base with the carpal bones. And that's again that light of day or daylight sign that this is normal. It's a nice demonstration of injury and then relocated. Okay. Okay, so yes, I agree. This is normal. Someone said perilunate dislocation. So a perilunate dislocation would be the capitate. It's not the clearest lateral. It's not a true lateral. So when we do a lateral radiograph, the pisiform, which is here, should be projected sort of over the middle of the scaphoid. So it's not quite centered properly, but that capitate is here, sitting on the lunate, on the radius. So yeah, normal. Yeah, so you're all spotting the fracture, quite an obvious fracture, transverse fracture through proximal shaft or the base of what I think is the little finger proximal phalanx. But yeah, as someone spotted, there is a bone lesion here. So this is normal bony architecture, trabecular pattern. And here there's disruption, there's lucency, probably some slight expansion, tiny degree of expansion. So the bony margins have widened and the cortex is thinned from the inside. But ignoring the fracture, the cortex, there's no periosteal reaction. And this is what we call endosteal scalloping, which is thinning from the inside of the cortex, both sides. So fracture, bone lesion there. Again, that's showing nicely that endosteal scalloping. And that's just a close-up of normal for comparison. So this lesion is beyond the scope of the talk, but it's probably an enchondroma. The most common benign bone lesion in the phalanges is an enchondroma. But I think for any of you reporting these in A&E or as junior doctors, nurse practitioners, things like that, I would say spotting the fracture is the key bit. Spotting the bone lesion is important, but that I think is where your limits sort of lie. Pathological fracture, so fracture through a bone lesion, and then leave it for orthopedics and radiology to work out what the bone lesion is. So yeah, pathological fracture. Next case. Okay, so so far limited answers. I'm going to take this to be that we're not sure. So we're starting to get towards the back end now. We've got 5 cases left. They're going to get tricky. So if you're not spotting these, I would not worry too much. Okay. What we've got here. So this one is quite an old radiograph. This one wasn't a current case, which I think is why people are thinking it looks a bit sclerotic. These bones, I think it's just the way the film's taken. There isn't really much degenerative change or OA. And these bones are probably normal density. It's just an old film, which was given to me. But what we're seeing here is if we're tracing the capitate here, sorry, hamate, yeah, hamate, there is a fracture. This bone fragment here, where's that come from? Yeah, exactly. Where's that come from? This cortex here, lucency, something's not right. There's a hamate fracture. So yeah, that's probably come from the hook of the hamate, which is why if we go back, something's not right, but there's no clear break in the cortex, but there's this fragment, and that's probably because it's the hook which projects sort of on top of the hamate, which is fractured and then move around the side. So yeah, hamate fracture. Line through the scaphoid. That's just normal scaphoid, and it's where the plane of the scaphoid is not entirely in line with the film, so it's slightly oblique, which is where we're getting this overlap, and that's normal. Nice and smooth cortices. Yeah, so hamate fracture, which is difficult to spot. That could very easily be missed. Okay, so we'll just run through this one. There's a fracture through the base of the thumb. Thumb base fracture. Okay, easy one. So while you're looking through this one, I'll show you here. So this again, hamate, and this bit here would have been the hook, which you can sort of see how a fracture here might be difficult to spot, and then it's displaced here. Okay, so I'm aware we've run over, so if anyone can quickly put an answer. Okay, so this one is normal. Capitate dislocation. So here's the capitate. Here's the lunate. There's the radius. So they're all in a line. So this is normal. Okay, so this one tracing the carpal bones, and yes, well done to all of you who've spotted. Here is a hamate fracture, but let's make sure we look at the rest of the film. So the alignment, so carpal spaces look okay, and edge of film, base of metacarpals look okay. Someone said carpal joint spaces look widened. I can see what you mean. There is a slight gap, but it's quite uniform. They all look fairly symmetrical on this AP. And then on the oblique, again, they do look symmetrical. And here we've got this hamate fracture. So there it is, there's that fracture. 2 films left. Okay, so we had a range of answers. So I've not seen a fracture. Some people have said lunate fracture, capitate fracture. No, I think they look okay. There's no break in the cortex, there's no lucent lines. And then let's look at the joint spaces. So this row looks okay. The middle row looks okay, and the distal space up here, space looks okay. And then between the carpal bones, this is wide. So that scapholunate interval is widened. Now, it's not as obvious as that first example that we saw, that was really wide, but this is not a symmetrical space. If we compare this gap to this gap, or to this gap, or to this gap, it's wide. And if you measure it, it should be less than 3 millimeters normally. So 3 to 4 is borderline, more than 4 is grossly dissociated. So yeah, scapholunate dissociation or scapholunate ligament disruption, correct answers. Okay, and this is the final film. And this one is quite a good real world film. The bone density is reduced, they're osteopenic, and they do have OA. So particularly here in the STT joint, so scapho, triquetrum, no, trapezium, trapezoid, scapho, trapezium, trapezoid joint, STT joint, and the base of the thumb. So the thumb carpal metacarpal joint, these are narrowed. We can see sclerosis, some cystic change. So that's OA. And I think the obviously old looking bones give us a clue to the injury. So on the AP, not particularly remarkable. again, we've said some narrowing here, but otherwise the alignment looks okay. And then when we look on the lateral, tracing the quarter-these, and here, so there's a step. And remember what I said, distal radius should be really, really smooth, and it's not, there's a step. And that's a distal radius fracture, which is minimally displaced, not particularly angulated. Everything's all lining up. But again, we're just not seeing it on this AP, and that's why reviewing the distal radius, dorsally particularly, on the lateral is really important. So distal radius fracture, we're seeing just OA up here. So yeah, there you go. There's your, oh, and bonus marks, there was a capitate fracture. Hang on, yeah. I just got distracted and hadn't looked at the rest of the film properly. There is a step in the capitate, bit of a loosened line. That's very suspicious for a fracture. There it is. So yeah, I got caught out going too quickly on the last case, trying to wrap up in time for you. But there you are, distal radius fracture and a capitate fracture. So that is all of my cases. Well done to everyone that's made it to the end. I know we've run over. I didn't know how many cases we'd get through, but we've got through them all. So thank you all for listening. Big thank you to those of you that have been participating in the chat. So Jeremy, Grace, Sabri, Roshni, Mustafa, just to name a few. There are more of you, but yeah, well done for trying to answer all the questions and actually getting most of them right. So if you want to take my email address, if there's anything else you want to ask, please do be happy to reply to any questions or take any questions from the chat if you want. Feedback form will be really useful as well. And I have loads of cases of osteoarthritis or arthritides, rheumatology cases. If you want another session at some point on arthritis in the hand, which is a really sort of classic medical school questions, where they show you the cases, but they could describe some of the findings, knowing the difference between osteoarthritis and rheumatoid, CPPD. So if you want that, I'm happy to do one. Just let us know on the feedback form. So yeah, that is it. I hope you managed to spot some of the abnormalities. And I think if you remember all of those findings, then there's not going to be much that you'll see in normal working practice that hasn't been shown on those cases. That covers pretty much all the common patterns of injury, including some of the more rare injuries and the important injuries not to miss.
Thank you.
Yeah, one question, sorry, I'll just answer this. Difference between a mallet finger and bony mallet. So the mallet finger describes, so a mallet finger is the deformity, where it's a flexion deformity. Bony mallet sort of is where there's a fracture causing that. Yeah, Kev, I'll hand it back to you.
Yeah, you've taught us a lot this morning, and thanks for everyone who's watching for being so interactive, because it definitely makes these sessions more interesting and educational. And I'm sure everyone will agree that the high volume of cases was particularly helpful for their learning. I think, as we all know, it's about seeing as many of these as we can, and I'll definitely apply this when I go into my next shift when someone decides to foosh themselves at 3 in the morning. Just to reiterate Henry's comments about the red dot, because there's been a couple of times that I've seen red dotted films in the emergency department, and it's quite difficult to identify the injury. And a quick chat with the radiographer will often reveal that it's quite a subtle injury that will sometimes just get reported the next day if we can't find it ourselves. So depending on your trust, if you have access to the imaging software, then sometimes the radiographers will leave a comment on why they've red dotted the image, so that can be quite helpful. So you should have all had feedback links emailed through to you already. If that hasn't arrived then that should come through in the next couple of minutes or so. But I'm also going to paste into the chat box now. Give me a second. So there's a few links in there. That first one is just goes through to the feedback link, so you can leave it for us. And that's how you get your certificate emailed through to you as soon as you fill that in. 2 weeks from now, so that's Wednesday the 8th of December at 8 in the evening, UK time, Dr. Joe Kang will be presenting a structured approach, common cases and pitfalls of lower limb MSK. So that's going to cover knee, ankle and foot x-ray interpretations. And the link to sign up for that is also in the chat box. And that last link is going to take you through to the Mind the Bleep website, where you can sign up for all of the radiology webinars that are left, as well as some of the other webinars that we do. So we do surgery, medicine, there's a finance one, there's a pediatric one to sign up to. So if you're interested in any of those, have a quick look on our website. I think there was a couple of questions that have popped up since I've been talking. Henry, I'm not sure.
So I think we're up to date with the questions.
Watch this session.
Can we? Yeah. Sorry, I'll let you carry on.
Yeah. So these will all get saved on Medal. So it takes a bit of time because it's quite a big file, but they will be able to be seen. If you go back to the link of how you signed up, if you look on the left-hand side, it should say recorded sessions or added content. And if you go on that, then you can watch this entire thing because it all gets recorded. I'll leave it a couple minutes or so just in case there are any other burning questions. But if not, thanks everyone for watching. Thanks, Henry, for doing so many cases and for teaching us all these different things.
Thank you, Kevin, for the invite to come and speak. And again, thank you everyone for being so interactive. It really makes delivering these sessions much more informative, I think, but also more enjoyable for me presenting, knowing you guys are there and listening. So thank you.
There's one last comment. With a mallet finger, I assume that non-bone injuries can result in that. Example, tendon-only injuries.
Yes. So the mallet, or that sort of flexion deformity, can be due to any injury that disrupts the extensor mechanism on the finger. So it could be a tendon injury or an avulsion injury. Most commonly it's an avulsion injury, but it can also just be a purely tendinous injury. So if you had rather than like a fall and a fracture, if it was a sort of like a sore injury or a laceration, you can cut the tendon, which would give you the mallet deformity but without a fracture. So yes, can be just tendons.
Fantastic. So don't forget to come back in 2 weeks' time. So that's Wednesday, the 8th of December for the lower limb MSK. The link for that is just above. And please don't forget to do the feedback form, and that link's above as well. But you should also have had an email come through. And once you fill that in, it means that you'll get your certificate. And it also means that we know how we can improve things, because we do look at the feedback. And one of the common themes is that people wanted more cases. So that's why we've tried to include that in this session. All right. It doesn't look like there are any more questions. So thanks, Henry, for delivering the session. Thank you, everyone, for watching. And we'll see you all on the 8th of December.
All right. Cheers all. Bye.